Assalamu alaikum. Thank you very much for waiting this long. I know it's a tiring day, long day for you, and there's lots of good presentation. I want to add just few cents of mine. Actually, most of the topic and most of the titles were excellent and it's quite good learning for me. Thank you very much, Prof. Pinyol, for giving me opportunity to talk on this in this crash course. So my topic is not very long. There are some short messages. I will go to that. So there are some question answer from there. So we can address the questions in the end if there is any from the previous talks. So yeah. So there are a few questions and you have to yes. Okay. So I'll answer this. Yeah.
But we will answer.
Yeah. So for the question, the people who wrote the question, we can answer that in the end of my talk. And Prof. Pinyol is coming back again for the talk, so he can actually answer those questions that time. So for my topic is I'm going to talk about the DCIS or ductal carcinoma in situ. So we all know that DCIS is the pre-cancer stage, and this is before the invasive disease. So mostly it presents as ductal carcinoma in situ at its own, or it can be as a Paget's disease of the nipple. The major or important part to keep in mind that DCIS should not be associated with invasive disease. If it is associated with invasive disease, then it is not a DCIS or in situ disease anymore. And also just one more update, which maybe most of the people would know, that the LCIS is now considered as benign disease and is not in situ disease, which is actually in the 8th edition of AJCC. They updated that in their system. So to remember, just to summarize on this topic, that carcinoma in situ, when it is not associated with invasive disease or is Paget's disease of nipple without having any invasive component in the breast, is actually called the in situ disease, and LCIS is no more in situ category. And we know how to write it. Is called stage 0 or TIS and 0M0. So moving on, so 80% of non-invasive cancer is DCIS, and it's a precursor lesion, as I told you, that invasive disease. And that precursor lesion means if we give the time duration over a period of years and years, this in situ disease can progress to cancerous disease. So it is confined to ductal system and actually did not penetrate the membrane. So by definition, it should not. And because it does not penetrate the membrane, so therefore it's limited to the ductal system, and it does not have the capacity to metastasize. So these are very key points, because we will discuss that in later, that why sometime DCIS and we have the nodes metastasis, so should not be. So as I mentioned that the in situ disease should not metastasize. However, in the rare instance, about up to 5%, in some literature 1% or less than 1%, 0.5 and up to 5% reported as the axillary lymph node involvement. So that would be surprising if it does not penetrate the membrane, and how can it metastasize? So what I would say that is actually the reason may be that we may not have detected the invasive portion of the disease, and we only found the in situ, but there would be somewhere metastatic disease, or maybe if it is a larger DCIS, there are times when there are microinvasion which can be missed in the slicing of the tumor. So once it is axillary metastasis, it should not be only in situ disease. The incidence of in situ disease has increased with mammography. So there are two main reasons for it. One reason is that, of course, we did a screening and we are detecting more. So we detected earlier. So instead of waiting for detection at the invasive disease, while we are doing that screening, we found it early. Because you know that in situ diseases many times are associated with microcalcification, and that microcalcification is easily detected on the mammogram. So this is one of the reasons. The other reason which I understand is that because in situ disease is also because of the X-ray exposure to the mammogram. So where there is an advantage of doing the screening that we can detect earlier stage and more curative stage. Also, there is X-ray exposure over years and years, and that can itself cause in situ disease or invasive disease. So these are the two reasons that why the mammography can increase the incidence of in situ disease. So it is of course a less common stage which we found than invasive breast cancer. And as there are some literature mentioning that 25 to 30% of DCIS can progress to invasive disease over 30-year period. So as I told you, it's precancerous stage. It means that it can progress to invasive disease if we wait for years. So it's a precancerous stage. So when the risk of recurrence of the in situ disease has multiple factors, it's not the same for everyone. So younger patients have a higher risk of recurrence, and that is maybe because they have longer longevity of life, higher grade, and as you know, as we have the theory that in situ disease can progress to invasive disease. Also, the higher grade can progress more easily to invasive disease. Comedonecrosis is as a negative factor, and that also can cause also multifocality, or if it is larger tumor size. Many of us know that when there is larger tumor size, there is sometime actually microinvasive focus within DCIS. Also, positive surgical margins. So of course, if the tumor is not completely removed, if the in situ disease is still in the breast, that can progress to invasive disease. We know that the hormone receptor negativity is a negative factor, especially in the triple negative disease. So that can also cause higher risk of recurrence. Ki67 is more and more role not only for chemotherapy, also for radiation, and as a predictor for risk of recurrence. So if Ki67 is more than, in some literature, 10%, in other literature, 14%, can also cause the risk of, increase the risk of recurrence. HER2 new amplification as well, and therefore there was an RTUG study to test whether Herceptin have any role in situ disease, which I'll explain later, and answer is no. Oncotype DX as well as a risk factor. So this is the very important slide that to mention that what is the management of in situ disease when we find it early. So in situ disease management, our main goal is to prevent it to progress to invasive disease. So in situ disease itself is not a problem in most instance, even though in some instance it does, but most instance it doesn't. But as long as we can prevent it to progress to invasive disease. So how do we manage? So as we know, in breast cancer, surgery plays a major role. Dr. Moza Lamri, if she's attending, she does the major treatment for the breast cancer and for in situ disease. Prof. Pignol have mentioned that how we progress in our management from larger mastectomy to lumpectomy and combining with radiation. So same thing in here. Not much different. If we do lumpectomy, we have to do adjuvant radiation treatment after the surgery. And if we do mastectomy, then we do not need, in most cases, we do not need to do the adjuvant radiation. In rare cases, we may still need to radiate, but most commonly not. So, and we all know that most common treatment, if it is feasible, is the lumpectomy with adjuvant radiation. But in some cases, mastectomy is preferred, which I will explain later. But majority to know here, surgery management is lumpectomy with adjuvant radiation or mastectomy alone. This is majority. Now we come to that radiation treatment. So when we said we do lumpectomy, do we need to do radiation? Answer is yes. So this is the early breast cancer trialist group, actually collaborative group, when they did the meta-analysis of 4 large randomized trials, and they found the benefit of adjuvant radiation because they assessed the patient with radiation, without radiation, and found the radiation has an important role, which actually reduced the 10-year risk of invasive, ipsilateral invasive breast cancer recurrence to be half. So it is from 28 to 13%, but is actually 50% risk reduction of recurrence. So that is very important. And also to mention something important here, and then I will explain in the future on the next slides, that is there any group where we can exclude radiation after lumpectomy? Answer is no. So it's there was thinking in the past that there may be where there may be some selective group of in situ disease where we can omit radiation after lumpectomy, but we did learn over a period of years and years that none of those group, but I'll show you why I'm claiming this. However, if we don't give radiation, adjuvant radiation, there we know that the risk of recurrence is double, which is almost like from 13% to 28%, or different studies have different numbers, but all of them 50% or double the number of recurrence. And if we don't do the radiation, so what will happen when the recurrence happen in those patients? They can still be managed because it may be still be limited to breast cancer. But then there are lots of psychological impact on the patient having recurrent disease. They may have to lose their breast because they have to go through the mastectomy. So those are the issues. Therefore, we prefer still to give adjuvant radiation. But if we don't, then the overall survival will not be differ as long as patient being regularly followed up. So now for the, I come to the point of systemic treatment. So we covered surgery, we covered radiation, come to the systemic treatment. So is there any role of hormonal treatment or any form of chemotherapy or Herceptin? So there was NSA-BP B24 randomized phase 3 trial, multicentric, and they were given the addition of tamoxifen in addition to surgery and radiation, and they found that there was a reduction of overall from 8%, so from 13% to 8%. So there was a 5% difference of adding the tamoxifen. However, there is 5 years of the side effect of the hormonal treatment as well. So this difference was considered to be not very significant, even though if it is, but however, there is a balance we need to manage between giving 5 years of hormone treatment with its side effect versus the benefit of by giving the hormone treatment without overall survival benefit. So this is a question mark. What I do to my patient, I explain them the benefit and the side effects of the treatment, and I let them decide whether they want to have the tamoxifen or not. And I'll explain you a little bit more in the future slides that tamoxifen or some other options as well. Now, I will mention here quickly about the HER2 positive overexpression. So in the tamoxifen trial, I forgot to mention that ER positive patient get the greatest benefit, of course. There was an RTOG study where DCIS patients were tested for HER2 overexpression, and if they were, then they were offered 2 cycles of Herceptin treatment versus not. That was a randomized trial. I enrolled the patient on that study. The challenge was on that study was, first of all, when you see the patient, which is in situ disease, many of them, we sent the testing for HER2 because HER2 was not a standard testing for in situ disease. So first of all, we have to bypass the system and request them on study to have their HER2 tested. And many times we are disappointed because when you are an investigator on the study, you want to enroll patient and you want to look for answer as positive, but many times answer come as negative, very few time answer come positive. And after that, when you enroll them on the study, if they come positive, then 50% chance to be Herceptin treatment or not Herceptin treatment. So it was like a very challenging to me as an investigator for that study. However, it gave us some answer. And the answer was there was no benefit of Herceptin treatment, but I'll show you in the other slides. Here, I just want to summarize. I want to explain you in a short nutshell that, what is the role of surgery, radiation, and systemic treatment. And now I will go to more into the details of it. So surgery, as we mentioned, that lumpectomy without lymph node, surgery, because technically we should not expect a lymph node positivity while there's in situ. But as I mentioned, up to 5% it can be because due to multiple reasons. And we can do mastectomy as when there is absolute or relative contraindication to radiotherapy, which I'll explain as well. or there is a widespread disease on the mammogram or on physical examination, or we find the biopsy positive from multiple locations. So that is another reason for to do mastectomy instead of lumpectomy. Also, when we think sentinel lymph node biopsy is important and we want to do that, most of the time we consider mastectomy at that time point. So when we do mastectomy, we do sentinel lymph node biopsy at the same setup and not to go back again later on. So sentinel lymph node biopsy is very helpful when there's microinvasion. Now, once it is microinvasion, this is not DCIS. However, we face this situation where the tumor is 4 centimeter or more, there's a higher chance of microinvasion. And in those cases, many times surgeon would prefer to do the sentinel node biopsy and also mastectomy. So the 10 to 20% of the patient who are diagnosed as DCIS only may have invasive disease after surgery. Keep this thing in mind, and we do selection case by case based on MDT. As surgeons and radiation oncologists can make that decision while they do MDT. So the absolute contraindication to breast conservative surgery in cases of in situ disease, if we have the persistently positive surgical margin, maybe after 1 or 2 re-excision. So it's better not to keep repeating the surgical re-excision, better to do mastectomy in that case. Or if there is diffuse malignant appearing calcifications. As we know, microcalcification is a hallmark for in situ disease. If it is on the multiple places, we may miss the tumor if we only remove one side. So it's better to do mastectomy in that case. Or if there are cases where we cannot give radiation, or we prefer not to give radiation, in those cases, mastectomy is priority, because by doing mastectomy, you do the complete treatment. There is no need for any additional treatment or adjuvant radiation. So, for example, if a patient have a prior chest or breast radiation for breast cancer or for lymphoma, that's our Royal College exam question sometime, previous lymphoma and now need breast radiation. So surgery as mastectomy is preferred, or a patient who's pregnant and need to have surgery and you cannot have radiation. In that cases, for the people who are going to appear in fellowship exam, can keep in mind in those cases mastectomy is preferred because we cannot give radiation due to child protection. These are absolute contraindication, but there are some relative contraindication as well. So if some people have active connective tissue disorder, like scleroderma, active lupus, AT, or rheumatoid arthritis. So, those cases, we expect more skin reaction. And if it is feasible and if patient agree, we can do mastectomy instead of selective surgery or lumpectomy. Or there is the tumor sizes or the DCIS bulk of tissue is, or cancer is, precancerous disease is larger in size, in especially a small breast. So breast to tumor size ratio is not making good cosmesis after surgery. In those cases, mastectomy is better with the implant if the surgeon and patient agree. So in those cases also you can consider mastectomy. Or tumor is multicentric, where the tumor cannot be removed in one surgery and they are in a way multicentric that they are far away from each other. These are the relative contraindication. So for radiation treatment, I would say that after any breast conservative surgery, as I mentioned, there is no group of the patient who can be spared from adjuvant radiation. I can explain more about what type of radiation, what doses, that's different. However, after every breast conservative surgery in situ disease, radiation is recommended. So it is actually decrease the rate of in breast disease recurrence at 5 years when it assessed. Some study assessed at 10 year, 15 year, and 20 year. Every time they assess at some distance, they find the graph is going away from each other. So it means the benefit increase as the number of years increase. So there is no doubt about radiation after breast conservative surgery in situ disease. Can we do partial breast radiation? So Florence study is one of the example where they did external beam-based ultra hypofractionated APBI, accelerated partial breast radiation, and they found good results. So that can be considered. And there's one of my friend Shaba who was with me in Ireland. and moved to Poland after that. And he did a study with the brachytherapy instead of external beam radiation with APBI. And he proven the equivalence of external beam radiation. So I read his study with interest. So that's also an option. And whether to, and this here I want to mention the name of Dr. Mansoor, who's working in Tawam. When I joined Tawam from Canada, and he asked me question, why can't we give the boost in the in situ disease? And my answer was no, because there is no evidence by that time. However, good news to Mansoor that he is the winner in this, and it shows that not all, but some cases of in situ disease can be offered a boost treatment with benefit. And I will show you a randomized trial outcome, which I just learned now while I was preparing for this presentation. So radiation doses and volume. We all know the standard doses in the past was 50 grain, 25 fraction over 5 weeks. That was the standard. And I was arguing with some of my friends who were offering 40 grain, 15 fraction in situ disease. I was saying to them, look, I know 14, 15 is equivalent to 15, 25 in breast invasive disease. However, it is not tested in randomized study, and therefore 14, 15 can be offered, extrapolating the data from the invasive disease. However, there are now randomized trial comparing 50 grain 25 fraction versus 40 grain 15 fraction, and they found not different, outcome is similar. So that is, and there are references listed in here. If you are interested, you can always go into those references. So 40 grain 15 fraction is a standard treatment for in situ disease adjuvant treatment. Ultra hypofractionation, as I mentioned to you, the APBI was used for partial volume and the ultra hypofractionated doses, and they found proved to be equivalent. However, those studies have not had the enough number of patients to only claim that, because those studies was having mix of invasive disease and the in situ disease. So there is no study which comparing in situ disease with moderate or standard doses of radiation with ultra hypofractionation. However, this is an option. You have an argument to say that because of those studies, patients were enrolled. So it's up to you, individual physician to physician, whether they want to do partial volume or want to treat the whole breast, and whether they want to do moderate or standard high doses, or they want to do ultra hypofractionation. That is your choice. Now, tumor bed boost, as I mentioned, this is a new to me. So whether tumor bed boost is any benefit or not. So there was a randomized trial where there was confirmed, it was assessed for 16 grain 8 fraction. This was sequential boost for non-low risk group of the in situ disease in phase 3 randomized. And it shows it was an international study in multiple country, in multiple center phase 3. And it shows, yes, there was a 5% benefit from 92 to 97%. So risk of recurrence, so the no recurrence happened in 92 versus 97%. But however, it increased the breast pain and in duration. So it is at a cost. So now for this 5% benefit, do you want to give the boost or not? Your call, you need to assess this clearly. I thank Prof. Pignol when he showed me a pooled analysis of 4,000 patients, where he showed that when there is a positive margin, there is a benefit of boost. So I would say you go individual case by case. You can do it. Definitely not in non-low risk group. It should be in the high risk group. Positive margin, I would definitely offer the boost. And now a new question come here. Someone should do the study, one of us, that whether we can do sequential boost or we do concurrent SIB boost, because invasive breast disease is a model for us, and it works for the radiation doses and volumes. It will work for the boost as well. So I think in future, there may be a study where SIB boost versus sequential boost for high risk or positive margin. So anyway, very important point about the boost. So I think you get the answer. You can in selective cases. So RTUG, so as I said to you, that is the radiation for every patient with the in situ disease? And answer is yes, because RTUG 9804 study, they did RT versus no RT in good risk group. And can we spare? That was the question, and answer is no, we cannot spare. So radiation is must. If you learn from today, from this topic, if we all learn, including me, if we learn, either mastectomy or lumpectomy with radiation, we learn. Because this is it. This is the message. We cannot spare anyone from radiation if we do lumpectomy in situ disease. This is the most important point. And you can see the difference is humongous. And this is in low or intermediate risk. They even included intermediate risk. Only they exempted high risk group. So now I must have to say this, meta-analysis, because meta-analysis is important. There's 4 large randomized trial and give us so many answers. I will flip through the slide, but very important slides will be coming. So as I mentioned to you, no impact on survival by RT. And I told you the reason, because they can be detected early and they can have the salvage treatment. But I prefer not to go there and will offer adjuvant radiation. Okay, so now I want to flip through some slides. So if you look at 5-year difference, 10-year difference, all 4 study, this is the plot here, forest plot, and you can see every single study showed benefit of adjuvant radiation, and combine all of them show the benefit. If you look at this, this diamond is still on the benefit side. And you can see the difference is 5-year and 10-year, and other studies 15-year and 20 years. The gap, if you see the gap is growing. And the gap is growing so much that I can even pass through the 2 lines of the graph. So you go see the 20, even if I be a little bit fatter, still I can pass through. So answer is you must have to give the adjuvant radiation. Now subgroup, there may be subgroup, we try to find whether extent of the surgery, lumpectomy versus sector resection is still benefit of radiation. Then whether margin status positive or negative, still radiation benefit. Even I will go in those cases with the 4 sequential boost as well. Whether histological grade, again, same thing, there is benefit. Nuclear grade, still benefit of radiation. Comedonecrosis, still benefit of radiation. Architecture, same. Age at diagnosis, whether 50-year or more than 50-year, any difference, even though difference is less, but still there. So benefit is still there, age not affecting. Method of detection, like some people say, maybe they were detected by mammograph only, or someone detected only with clinical symptom. Would that make a difference? No, still answer is benefit from radiation. So radiation benefit across. And as I mentioned to you, that positive margin is very strong indicator for adjuvant radiation, more so for the boost. So now on, after this presentation, if I see a breast cancer patient, DCIS, positive margin, I will do the boost. Whether I would do sequential or SIB, that's a question to remain to be answered. It's very important also to know that, the how much margin. So I will little bit talk about here. We all know now after one publication that ink margin, no cancer means no, it's a negative margin. That's for invasive disease. We all learn, and it's a big change in the practice, even though I would have some reservation because that was retrospective analysis, and still practice has changed. So not going there. But that doesn't apply to in situ disease. So we need to keep in our mind that minimum margin requirement is 2 millimeter for the in situ disease. So again, this is most important. One of the very important point here in this talk is that as invasive disease, not on the ink margin is enough. So clear margin for the in situ disease, we're looking for at least 2 millimeter of clear margin. More than 2 millimeter, no benefit, but less than 2 millimeter or positive margin, important. So here you can consider less than 2 millimeter, whether boost or not boost, but it is important to know 2 millimeter is important factor. So we come to this part, that tamoxifen or not tamoxifen. So you can see the difference is less, and this is according to age. And we found according to age that that's few percentage overall, like 2.7 to 2.3%, and that's for this that tamoxifen. Generally, I am not recommending my patient to go for 5 years of hormone treatment based on ER positive in situ disease. However, after this study, I will present to patient that there is some advantage, which is very minimal for the side effect. But one study I want you to know here today is TAM-01 study. So this TAM-01 study is very recent addition to the literature, which is in 2023 JCO publication. They said, okay, 20 milligram of tamoxifen for 5 years, give the toxicity for a small benefit. How about if we give 5 milligram of tamoxifen for 3 years, not for 5 years, would there be any benefit? And they showed, yes, there is some benefit. I would recommend you to go into that study to read, and then you can make your decision whether you want to offer tamoxifen or not. So before I move on, I just mentioned to you that there was another study, which maybe my slide is somewhere or I miss it during presentation, that there was postmenopausal patient. They tested Arimidex compared to tamoxifen, and it's postmenopausal, it's equivalent to tamoxifen. Of course, premenopausal, I will not offer Arimidex, but postmenopausal, you have choice either to offer tamoxifen or Arimidex. Now, since that study of TAM-01, I would prefer tamoxifen because they did give low dose for shorter duration. Now, as I mentioned to you, NSABP 43 study, HER2 overexpression, and I mentioned to you about the 2 cycles of Herceptin versus no Herceptin, and that there was no additional benefit, and it was detrimental. I followed the patient, and I found they were having the side effect. So, no to Herceptin. So this is the one, sorry, here you come the TAM versus anastrozole, and you see there is no difference between them. You can explore that. And with this, coming to conclusion of my time and conclusion of my talk, I will repeat those things, which is important. So in situ disease is the one which is in situ disease in breast or Paget's disease of nipple without invasive disease. So that's number one. Number two, LCIS is no more in situ disease. It's a benign condition and is coming in AJCC 8th edition as not in situ disease. Management option. One option is breast conservative surgery with adjuvant radiation. You can decide about the dose, fractionation, and volume for adjuvant treatment in every PCS patient without any selection to be out of it. Mastectomy is equally standard treatment with or without sentinel node biopsy. And in some cases, it is more important than the other. And mastectomy is legitimate and equally effective option of treatment. Then adjuvant RT will reduce the risk of recurrence by 50% in all groups. Tumor bed boost can be considered in high risk group, especially with the positive surgical margin. I would give to every positive surgical margin, and I'll consider somewhere between less than 2 millimeter margin as well. Doses of radiation, now 15-25, 14-15, or 13-5 alternate days. And the sequential boost when we give, it is 16 gray in 8 fraction. Whether you want to consider SIB boost or not, I'll leave it up to you. And then a hormonal therapy can be considered tamoxifen in all age group or anastrozole in perimenopausal. Herceptin is no go. So these are my conclusion points. And with my time, I say thank you very much for attending.